Let's get started. So it is my pleasure to introduce today's guest speaker, Dr. Shaoxiong Chen. Dr. Chen had his medical training in China and completed his Ph.D. In biochemistry and molecular biology at Tulane, followed uh, by a postdoc fellowship training at UCLA, and he finished his APCP residency at the University of Toledo, and followed by a surgical pathology fellowship training at MD Anderson, and then cytopathology training at Indiana University. He stayed on as a faculty at Indiana and until now, and he got promoted as a tenured professor last year. Dr. Chen is active, Dr. Chen's practice largely focus on cytopathology and bone soft tissue pathology, and he's very active educator and clinical research, and he wrote a couple of chapters, including a synovial sarcoma in the WHO classification of GU tumors. And he's very scholarly active, and he published, I believe, over 60 peer-reviewed manuscripts. As a matter of fact, the reason I got to know him about 10 years ago was that he reached out to me at the time and asking for a collaboration on a chondrosarcoma project. We published a nice paper together. Without further ado, Dr. Chen's topic today will be advanced in the classification of undifferentiated small round cell sarcoma. Welcome, Dr. Chen.
Yeah. Okay. Thank you. Thank you, Dr. Wei, for a nice introduction. And also I want to thank Dr. Maggie for offering me the opportunity to visit the wonderful department here. So today my talk, I will talk about undifferentiated small round cell sarcoma. Can you hear me well? Okay. So this latest WHO edition of soft tissue bone tumor blue book has a dedicated chapter for undifferentiated small round cell sarcoma. This tumor are rare, have an overlapping morphology feature. They can be challenging to make a diagnosis. Creation of this new chapter reflects the advance in small round cell sarcoma, particularly about the molecular alteration. So this group of tumor is further classified as Ewing sarcoma, round cell sarcoma with EWSR1 non-ETS fusion, chip-ringed sarcoma, and sarcoma with a SPICOR genetic alteration. Today, my talk will be focused on Ewing sarcoma, EWSR1 non-ETS fusion, and chip-ringed sarcoma. To work on this tumor, we should order the statin, FISH, or NGS. Also, be familiar with the classification. Do not panic. Avoid a diagnosis pitfall. Ewing sarcoma, I will discuss 3 different cases. Also, will mention the cytology feature too. So this is a 31-year-old male with a mass in the left tibia, and the tumor also grew into the soft tissue. As you can see here, histology shows sheets of round cell with a relatively uniform nuclei, fine chromatin, small nucleoli. And the lesional cells are diffuse positive for CD99 and the FLI1. And the cytology direct smear also shows similar feature with a uniform cell. And then, so the differential diagnosis, include all this round cell sarcoma Also include the poorly different synovial sarcoma, alveolar rhabdo, and a desmoplastic small round cell tumor. And I think lymphoma, small cell carcinoma are less likely, and also better included in your differential diagnosis. The EWS1 phase show the gene rearrangement as demonstrated by the orange signal is separate from green signal. Put all the information together. So this is the human sarcoma. In addition to the classic morphology, sometimes you may see the necrosis. I'm not sure the pointer work or not. The pointer. You see the necrosis, and you may see this vacuolated cytoplasm. Doesn't mean has a glycogen in the cytoplasm. This is another case. Is a 40-year-old male with a pancreatic mass. It's a single mass, 2.7 centimeter. Also has a lymphadenopathy. So we know now we use FNA. FNA a lot of GI tumor are diagnosed by FNA. So the direct smear also show this uniform cell. You know, if you look at the morphology, that does not look like endocrine tumor. Endocrine tumor more kind of polypocytoid, salt pepper chromatin. You will see more nuclear polymorphism. Rather than here, you can see more uniform. It's not a solid pseudopapillary tumor, which you can see the kind of pseudopapillary structure, and you can see this hyaline globule. And it also is not acinar cell carcinoma. Acinar cell carcinoma, you can see the acinar structure of a prominent nuclei. So this likely is something else when you look at the morphology. And this is a difficult. You may see this tigroid background. Sometimes it's not always. Sometimes it's terrible. Another tumor you can see a tigroid background is a seminoma. It's a good feature. Actually, section from cell block, you can see the cluster cell. Also, you see the single cell, and lesional cell are diffuse positive for cytokeratin, and also diffuse positive for NKX 2.2. Sometimes I noticed that CD99 immunosuppression does not work well on the on the cell block. It's only see kind of patchy weak stain. And this tumor, these cells also negative for INS1, synaptophysin, and chromogranin. And the NGS show EWS1, FLA1. So this is the final diagnosis of Ewing sarcoma. It's not that common. Ewing sarcoma can occur in the extraskeletal side, and it can occur all different sides, including kidney, pancreas, and the other sides. This another case is a 41-year-old female with a pancreas mass, as well as a multiple mass in the peritoneal sites. This is biopsy. Biopsy was performed. You can see this sheets of blue cell with fine chromatin. All this lesional cell are separated by dense fibrous tissue. And also you will see this smallness of lesional cell, the mix with the fibrous tissue. And the lesional cells are strongly positive for cytokeratin. And they're also positive for synaptophysin. And the K67 is pretty high. However, chromogranin and INS1 both are negative. So the original diagnosis is because based on the cytokeratin and synaptophysin, the tumor was called well-defined neuroendocrine tumor, grade 3. And then the palliative chemotherapy was started 4 months later, NGS was done and show EDOP S1FLA1 fusion gene. So the amended diagnosis is the Ewing sarcoma. This is one of the diagnosis protocol for Ewing sarcoma. They can be positive for strongly positive for subkeratin or synaptophysin. So we'll go back. The additional stain will perform the original biopsy. You can see the cell positive for CD99, diffuse positive for NKX 2.2. So after the chemotherapy, so they give the Ewing protocol treatment. After the treatment, you can see two cell population, kind of like a pale cell, also the blue cell, the dark cell. The dark cell is actually those cells who are dying. That's why you see the two cell population. And also after chemo, you will see more dense fibrous tissue in the background, and then you will see necrosis, and then you will see more cytology tissue. Look at all this cell, irregular nuclear contour, polymorphic. So it's more as a due to treatment effect, and also you see the lymphatic invasion. Because if you look at the neurochemical morphology, so this look at different model. Even this is grade 1, you can see the cell form nesting glandular structure, and it has a kind of lot of granular cytoplasm. So the morphology is different than Ewing sarcoma. And for grade 3, you will see a lot. You will see easy to see the mitosis, and you will see the necrosis. So the morphology is different. Yeah. So the histology and cytology, I think, is different than Ewing sarcoma. So this was a study published last year. They collected 23 of extraskeletal Ewing sarcoma of GI and hepatobiliary tract. And in this study, they said only 70% of cases were initially diagnosed Ewing sarcoma. Most common misdiagnosis include neuroendocrine tumor because the immunostain, synaptophysin, and other neuroendocrine marker. And then, so all these cases were confirmed by detecting EWS1 gene rearrangement. So you can see that this is a table from the paper. Say 33% of cases are positive for cytokeratin, and 67% of cases are positive for synaptophysin. It's pretty high. So if you're aware of this the pitfall, I think you will be able to make a correct diagnosis. When we talk about the Ewing sarcoma, it's better mention the NKX 2.2 immunostain. So this is a transcription factor. It's upgraded in Ewing sarcoma. The one study that collected like 30 genetically confirmed Ewing sarcoma and 130 non-Ewing small round cell sarcoma. They found the sensitivity, the NKX 2.2 sensitivity for Ewing sarcoma is 93%, and specificity is 89%. This NKX 2.2 can be positive in the olfactory neuroblastoma and cerebral sarcoma, mesenchymal chondrosarcoma. And yeah, they pretty like for mesenchymal chondrosarcoma, about 1/3 of cases can be positive. This is another study by Jason Harnick. He also added more small round sarcoma, like a cheek duct sarcoma, B-cord rearranged sarcoma, and classified sarcoma, and they found really the NKX2 is rarely expressed in cheek duct fold sarcoma and classified round cell sarcoma. It's really low percentage. and negative in the B core rearranged sarcoma. However, 80% of factor neuropathy can be positive, and 75% of mesenchymal carcinoma can be positive. So, because the mesenchymal carcinoma can occur in the bone, they have two components: atypical cartilage and the round cell component. If biopsy only showed round cell component, they are positive for CD99, positive for NK2.2, or the can be the issue. But if you wear this compared to radiology, you'll be able to avoid any mistake. For the EWSR1 associated tumor, and the majority is negative, really, rarely expressed in like myeloepithelial carcinoma and like desmoplastic small round cell tumor. So this and it's still pretty useful marker for Ewing sarcoma. Okay, so to summarize immunostain, for CD99, you want to see diffuse strong membrane staining. The NK2.2 has higher specificity, and this tumor can be positive for keratin, certified ERG. ERG is positive in the case with EWS1 ERG fusion gene. Ewing sarcoma is the second most common bone tumor in the pediatric population. Radiology can show that kind of onion skin appearance, and the extraskeletal Ewing sarcoma has a wide anatomical distribution. When you see the glycogen sort of which is not a specific finding, can occur in other soft tissue tumor too. Sometimes we make a typical Ewing sarcoma, which means a tumor larger with prominent nucleoli, irregular contour, but still has same fusion. But the atypical Ewing sarcoma can mimic a chick duck sarcoma, and you may see the homoradicate rosette. Doesn't mean indicates a neurodifferentiation. The WHO definition of Ewing sarcoma is a small round cell sarcoma harboring fit ETS fusion. 90%, 85% cases contain EWSR1 FLA1 fusion, and 10% contain EWSR1 ERK. FET means it's an acronym for three genes: FAS, EWSR1, and TAF15. The other in the classic partner FLA1 ERG, sometimes you may get the other partner include ETV1, ETV4, FEV, and also sometimes you could have FAS instead of EWSR1. So this is different fusion gene. If you look at the EWSR1 FEV fusion gene, it's about 15% case has this fusion gene. Is third most common fusion gene, occur in the older age, occur in soft tissue. Compared to classic FLA1 ERG, they have poor prognosis. If you see the 5-year disease-specific survival, really they're worse. In the older literature, you may see the term PNAT. So now it's no longer recommended the term that we use Ewing sarcoma. Okay, now there is regarding this EWS1 FLA1 fusion gene, we know it occurs in Ewing sarcoma. However, also occur in the adenoma-like Ewing sarcoma, and this occurs in head and neck region. Show the squamous differentiation Yeah, it's also positive for CD99 and Cas2, Sarcomas P40, P63, because squamous differentiation. And how to classify this lesion still has a different opinion. Yeah, is it urine sarcoma or the different entity? So still has some debate. And recently, there's another tumor called superficial neurocritic fat ETS fusion tumor. So this tumor also has the same built in as a human sarcoma, and it's a clinical indolent tumor skin and a superficial soft tissue. They show the morphology really kind of have similar morphology as a human sarcoma, but lesions are diffuse positive for S100, SOX10, also diffuse positive for CD99 and Cas2. Last year there was 5 cases reported, and this year has 5 cases. So far, has 10 cases reported in the literature. I say you never know. Maybe you can see the tumor sometime. Yeah, but for sure, the fusion is not unique to your sarcoma. Can occur in the other lesion. So this is everything about the human sarcoma. Regarding the EWT1 non-ETS fusion sarcoma, or mentioned 2 cases. 2 cases. This is the first. This is 21 years old male with a right tibial lesion. The patient has a right leg pain for 4 to 5 years, and getting worse. And the image show cortical destruction. So you can see here this show the cortical destruction, and also grow into the soft tissue. The MRI grow into the soft tissue. Is kind of aggressive. And then histology shows this kind of round epicellular cell with oval uniform nuclei, fine chromatin. And another thing, compared to human sarcoma normally for sheets of cell, but this tumor you see a lot of collagen, kind of fiber looking. This is peculiar collagen in the background. And also the a small, really very small nuclei. I think this clear cytoplasm and all this kind of funny collagen in the background. And also the growth pattern, they form nesting because the nesting cells separate by this kind of fibrous collagen, and also infiltrating growth. So this is recovered. The patient originally after the biopsy, the tumor was resected, and 2 years later recurred. And also you can see some kind of like a spindle stroma cell like this fibroblast in the background too. And you may see some kind of like a spindly cell, and look at the cytology, more atypical than human sarcoma. Irregular contour, polymorphism, compared to humans are more very uniform. And the EWSR1 fish did. The first thing you notice, this is a gene where you can see this orange signal and green signal separate. Doesn't mean there's a gene where. Another feature you can see is a really good feature. You can see the EWSR1 5' amplification. It's a really significant amplified, only 5' amplification. And also NGS was done. This was show EWSR1 and FAT-C2 fusion gene. So final diagnosis EWSR1 and FAT-C2 sarcoma. So this tumor, the lesion cells are positive for CD99, and it's the same as the urine sarcoma. I said morphology is different, but immune cell are pretty similar, and also positive for NKS 3.1. NKS is negative in the urine sarcoma, but for the EWSR1 and FAT-C2 is positive, and also you can for cytokine you can see the dot-like. Something has dot-like a positivity, and the marker for negative, and also positive for status B2. And sometimes you may see the growth pattern. You can see that's the motion pattern for this tumor. And And also, tumor maybe there's no matrix, it's a loss of matrix, it's more sheets of cell. But still, if you look at cytology, this is more atypical than Ewing sarcoma. You look at all the cells, really polymorphic. And they maybe from strands, and then you see the necrosis too. They look like more aggressive. Additional CD99 and CD2 is some kind of positive for WT1 and EMA, SMA. I think no, this is all really not that kind of specific, but it can be positive in all the marker. EW1 and FAT-C2 translocation associated sarcoma dominantly occur in the bone. So the bone lesion, clinically, frequently painful and have show local cortical destruction, and also more commonly occur in the male population, like a male to female is about 1:1. The main morphology feature for this tumor, is kind of round epithelioid, and you can see this kind of another motion course, and you can see the kind of fibrillary, the kind of collagen in the background, and immunostain. There's another feature, you kind of dot like a subkeratin. It's not diffuse, but you can see some cells have dot like. And this tumor has a poor histological and radiological response to Ewing sarcoma treatment protocol. Does not respond to the Ewing sarcoma treatment protocol. If the tumor lost the matrix, they can have an overlapping feature with Ewing sarcoma and myoepithelial tumor. The immunocyte marker NKT is positive in the EW01 and FAT-C2, but negative Ewing sarcoma. Another study is accurate Chen as positive in this tumor. I have not used this marker, but if you look at the literature, they say this accurate Chen is a good marker too. Okay, different diagnosis. Ewing sarcoma, really is sheath-like growth. No, most tumors don't have matrix, and then they're very uniform. And EW01 and FAT-C2 more polymorphic. This can mimic a myoepithelial neoplasm, but myoepithelial tumor positive for P63, SOX10, and the NKS2.2 should be negative. The tumor can have a local recurrence, also can have a metastatic disease. The overall prognosis has been somewhat variable among different studies. This is a 73-year-old male with a soft tissue mass. That's like a 2.7 centimeter mass. Is well circumscribed, located in the left posterior chest wall. So this is the patient came to our hospital for treatment. The other side reviewed by two different institutions. They call pleomorphic rhabdoid sarcoma. So if you look at morphology, it's a well circumscribed. And if you look at the cell, also kind of round epithelioid, you can see prominent nucleoli, and you can see kind of pleomorphic. And also you have this kind of fibrillar collagen in the background too. Kind of little bit kind of similar to the previous case in EW01 and FAT-C2. And one good figure is this lesion always has some cyst lesion. the cyst, and it has some kind of pinkish material, kind of look like a thyroid, colloid. It's a kind of colloid in the cyst, and you will see more cytology TPL and irregular contour, prominent line, and the collagen background. So this is immunostain, and MALD1 really a lot of cell positive, a lot of cell positive, and myogenic is negative, and also has a focal positive for desmin, and K67 is pretty low. So here show you the workup. The lesion cell also negative for cytokeratin, substance SMA, myogenic, ERG, CD34, and melanoma marker. And chromosome macro-array is unremarkable, and the ETS1 show EWSR1 part Z1 fusion gene. So the final diagnosis is EWSR1 part Z1 sarcoma. So you see the same. Which one better? So okay. Okay. So you can see this is cyst, always see kind of cyst, and you may see there's a fibrous septa. Sometimes you may see this thickened wall vessel, and it can be very cellular And you may see this cell can be spindly, individual round, so you can see spindly, maybe epithelioid appearance, and then also maybe see the kind of degenerated nuclei. Or maybe also can see the rhabdomyoblast differentiation or the rhabdomyoblast differentiation, and you may see the necrosis, and then you also maybe can see kind of infiltrating growth compared to my case. This is picture from the literature, kind of infiltrating. They have all different pattern. And the myogenic doesn't highlight rhabdomyoblast, and the lesion cell also can be positive for S100 and 1000. This immune super kind of confusing. The positive or a lot of different marker. Also positive for GFAP, and sometimes you can see the scatter cell for myogenic. My case is total negative. Sometimes maybe say the scattered myogenic expression. And for high relation, you may see this kind of a hypochromatic atypical nuclei, and really have very scanned matrix in the background. In the background. So far about maybe hello, yeah. So far about 50 case report in the literature have this fusion gene, and all this case reported exclusively occur in the soft tissue so far. So the main feature, as a good feature, look for this kind of micro cyst spaces with a pink material in the cyst. And the morphology can have kind of high grade, low grade, high grade morphology, and also can have epithelial appearance. You can see the rhabdomyoblast. So immunohistochemical profile is kind of polyphenotypic, like a co-expression, because we have skeletal muscle, epithelium, Schwann, and glial marker. So it has all this kind of multiple different marker. This tumor, this EWS1 Pathology fusion is thought to be the result of the cryptic paracentric inversion. So when you're doing the fish normally should not work because it's a cryptic paracentric inversion. The differential diagnosis include rhabdomyosarcoma, myelobacterial tumor too. So you can do some additional study. And another thing, this effusion is not unique to soft tumor, and also happen in the central nervous system tumor too. Regarding classification, so the question is, could it be this single entity defined by this molecular event? Also could it be more than one tumor type harboring the same fusion gene? Or could it be this could be a distinct subtype of fusion-driven rhabdomyosarcoma? So all the questions remain to be elucidated. So far we need more cases, and I think the progress is undergoing, and there's a limited data for prognosis. Also metastasis can occur. In my cases, patient after complication, so far patient doing very well, no recurrence. So for this EWSR1 non-ETS fusion gene, so we're talking about partner in phagocytic, PALZ1, also has other partner like SP3 and other gene. Okay, so there's another one also is round cell sarcoma. And so this is a 15 years old male with a big mass in the right gluteus maximus muscle, and also has a multiple lung mass. So this is clinically indicated this tumor is very aggressive, a big mass, and already has metastasis. So if you look at morphology, yeah, kind of similar, is round, but maybe a little more pleomorphic. And then also you maybe can see some kind of spindly. And this thing, CD99 positive flowers, kind of look like a urine sarcoma immunosuppressant pattern. Yeah, also kind of both are diffuse positive, and the CD99 also diffuse membrane stain. And the lesion cells are negative for Desmond, myogenic, MyD1, also negative for CD45. The differential diagnosis, I think for the round cell sarcoma, we have a similar list of different diagnoses. You wrote all the different subtype of round cell sarcoma, also include rapid or poorly diffused cerebral sarcoma and other tumor, neuroblastoma and lymphoma. So NGS was done, is check DAC4 fusion gene. So this tumor can have this tumor, or you may see prominent nucleoli, and you may see necrosis, and it can have a rhabdoid appearance and epithelioid appearance. Yeah, we need familiar with this CD99 immunosuppressant pattern. About 23% cases can show diffuse positive CD99. We know CD99 always diffuse positive in the urine sarcoma, and 61% kind of patchy staining and 60% negative. They are also positive for WT1 and also positive for ETV4, and both are positive. I do not have I do not have ETV4, but in some institutions they use ETV4. This tumor occurs in the deep soft tissue of the limb and trunk. And also like a 10% of cases can occur in the kidney, GI tract, and brain. The morphology, they can have like a solid and nodular growth pattern. And compared to Ewing sarcoma, they have a higher degree of variation in nuclear size and shape. 1/3 case has a myxoid change and also has, some cases has a geographic necrosis. So for the stain, so now in some of them we use DOC4 and WT1 and NKS2, NKS2.2 should be negative, generally negative, and the cytokeratin also negative, cytokeratin negative. In addition to DOC4, also all the partner FOXO4, not M1 or different partner. I think you really need to do NGS to show you a different partner. Compared to for all the round cell sarcoma, always compared to Ewing sarcoma. If you compare yourself, Ewing sarcoma, the prognosis is worse. The secret range sarcoma 5-year survival is 43%. However, Ewing sarcoma is 77%. So there's a significant difference. The one of the diagnostic for this tumor, the secret range sarcoma can be positive for CD31 ERG. So maybe you think, oh, if you somehow you order CD31 ERG, you're thinking maybe it's epithelial angiosarcoma. So this is one thing you need to be aware. And this is highly aggressive. The 5-year survival rate really is relatively low. So this is a review paper. There's a figure that summarizes all the feature of a small round cell tumor, and if you look at this figure for Ewing sarcoma, if you look at morphology, Ewing sarcoma, the morphology really look at the nuclei really like uniform, very uniform, and the stain. The stain you can normally I do like 3099 and gets 2.2. If when you look at morphology, you think Ewing sarcoma. Also you can do you can add a cytokeratin and also either you do fish or you can do NGS for Ewing sarcoma. For cheek ridge sarcoma, and also the kind of round cell morphology, but more pleomorphic, and then the CD99 really is positive in all the small round cell sarcoma, and then they're also positive for WT1 and ERG, and cytokeratin should be negative, and NKS2.2 should be negative. So this is cheek ridge sarcoma. For EWS1, part Z1, rare ridge sarcoma, they may this kind of multiple cysts with eosinophilic material content. That's a morphology feature for immunostain. For immunostain, they can be positive for Bateman, myogenic, MyD1, and also kind of positive for S100 keratin. So the NGS will show you the fusion gene. For the EWR1 and N5C2 rare sarcoma, this is kind of February collagen in the background, and then the NK and the keratin have kind of dot-like appearance, and also positive for NK X3.2. In addition, the EWR fish It's a really good feature. It shows 5' amplification, also positive for NKX 3.1, and also for aggregate positive. So this is kind of simplified summary of the tumor. So another sarcoma, the B core variant sarcoma. So I think not I think this one normally if you look at morphology, they have kind of mixed soil background, and then also you can see the prominent capillary network, but it's this we need to take a additional maybe 20 minutes to talk about the other one. I think overall when you work on the round cell sarcoma, look at the morphology first. Also, for the immunostain, make sure you avoid some trap. Yeah, there's some because sometimes the stain is not specific. I think always doing some fish or NGS, and then I think you'll be able to come with the correct diagnosis. Yeah, the same. We look at all the name, really look like making you feel pretty challenging to make a diagnosis. However, if you familiar with this classification, know there is some key feature, I think you should be fine. Yeah, don't think. Yeah. Okay, thank you very much. Yeah.
Great presentation, Dr. Chen. I have a question. So, when we see these markers, do you think it is also possible that these markers expression changes by stages of the sarcoma as well? Because if we see the immune sarcoma and its sticking point with the is missing from the other two, but it again is there in reanimated sarcoma. Is it possible that it not expressed in certain stages, but present in other stages?
This is a really good question. Yeah. I'm not sure it's the stage related. Yeah. Normally when we get a tumor, only major difference is size. Some maybe get a smaller tumor or maybe get a bigger tumor. Some morphology look pretty similar. Yeah. I think maybe earlier stage, maybe only like 1 or 2 a few cell stage. Maybe genetic profile is different, but it will be very hard to tell. Normally, your only tumor grow into a certain size, and then you make a diagnosis. Yeah. I think it's definitely there's. I think the fusion gene should be there at the beginning. Maybe when just 1 or 2 cells should be there. Gradually later, they maybe have additional molecular change or protein. Some gene are upgraded, some gene downregulated because there always there's something going on. Yeah.
Question. So US sarcoma is now molecularly defined and here. Okay. So now the market is none of the market is either sensitive. Well, some markers are sensitive, and some are more specific, but none of them 100%. So they don't have an in-house molecular lab, right?
The NGS we haven't sent out. Yeah.
You haven't sent out.
Yeah.
So for us, probably we're in a better position.
Yeah.
So for us, just over a few markers for screening purposes, and then go with whatever. So I don't have any revision to yes. So and typically, small biopsy, you don't have much to work with. You want to preserve tissue as much as possible. To answer your question, there's no Swiss marker. I'm not surprised if the use are correct express any marker or be negative. So, about 30% is a marker positive, and this has been known for that.
Yeah, I think here has He has really good molecular. Well, sort of cigarette really spoiled. Yeah, you got all the.
Why the spoil
When you're in KX 2.2 positivity, mesenchymal chondrosarcomas were very high.
Yeah,
Both tumor types are extraskeletal.
correct.
Both are mesenchymal.
Yeah.
You think there's a driver mutation in that independent of the gene fusion? Two entities?
I know in the human sarcoma, because the EWS1 is a transcription factor upregulated in case top 2.
You know what's driving it in mesenchymal chondrosarcoma?
I do not know about maybe.
There is this fusion, and which is now it's also molecularly defined in mesenchymal chondrosarcoma. It's only one. It's not like neurosarcoma. But there's only one.
Yeah, the mesenchymal chondrosarcoma, yeah, occur in the bone, and the urine sarcoma both come in the bone. So they can very have the round cell component of mesenchymal chondrosarcoma has very similar morphology. Normally, I need to do at least I need do some molecular data before I sign out my report. So far for soft tumor, only good immune marker is for cerebral sarcoma is the SS18, SSX, because that marker target like SS18 as a target fusion site. That does not exist in the nature, because the antibody only target the fusion site. That's why it's so 100% specific. If it's positive, it's positive. It's very specific. That's so far that's really good marker. And the other marker have not. The only marker where it's really 100% specific marker. That's why people. People talk about maybe you can develop some antibody for urine sarcoma, because urine sarcoma has all different fusion genes, but you can develop individual antibody for EWS1, FLA1, fusion side, EWS1, and then mix them together as a cocktail. But that's why I think because they may have enough the market support to do that. So that's why it's not available. But ideally, this should be a good approach too.
But for some place with no overlap.
Can I?
Oh, sure.
So mine is more of a comment, maybe a little bit of a question. So one thing about synaptophysin, and I think I don't want to lose the opportunity to say something about that, because we should never call anything a endocrine tumor if synapto is the only thing positive, because it's the most ubiquitous state that is going to be positive in a whole lot of things.
Yeah.
So, and I think that was reflected in one of your first cases.
Yeah.
Just want to point that one out. The flip side, which I don't know if the lung people are here, because they are probably the most confused part of pathology. Yeah, now recognize small cell neuroendocrine carcinoma that is negative for everything, synapto and everything. And I don't believe anything like that exists, because neuroendocrine tumor is defined by the presence of neurosecretory granules.
Yes.
So if it doesn't have neurosecretory, it cannot be neuroendocrine carcinoma, right? And I think so some of the things that you are beginning to show now is for the trainee, it's showing us that we as clinicians, we cannot just be inner retentive and be quite obsessed about one or two markers and say because we see. We need to look at the big picture, and if something doesn't fit, that's the time to put on the brakes and be able to ask the question. It's a good thing now that we have all this molecular thing, but even that one has its own problem, right? Because we don't want to rely too much and say, because I see a rearrangement, that is what, we are doing. So my comment is, I think this is a very beautiful presentation that just shows us how things can look like what it's not.
Yeah.
And we just have to be very, very careful. Now, my small question is about the FEP, AWSR, and FEP arrangement. So do we have to look for that particular rearrangement now because of the prognosis? Or what are you guys doing? Are you required in that?
And the treatment protocol is same, only the prognosis is different. Yeah, that's only for clinical purpose. Yeah. So now the reason sometimes why for all this renal cell sarcoma, the treatment is same. Before the checked up sarcoma, because we call Yuan-like sarcoma. So now because we now know more about molecular change, for pathology way ahead medical oncology. We're trying to have more specific diagnosis, but for clinical, and also I think they all different entity. The clinical behavior is different, but the treatment so far same. They don't have treatment same.
So how do you actually test? You dish, right?
Oh, well, here we do NGS.
Okay,
So just, you know, give us fusion. So the number is small, outside of the blood, guys on fly one, and then what the ERG, it's a little bit, 1 or 2% for every single. So it's important to look at the prognosis, the data, number one. Number two, I wouldn't just do a fish for EWS1 and call it USRL because now the definition is FET, yes, fusion. So there is, now it's EWS1, non-ETS fusion tumor. So it's a separate tumor classification. But things may change with more things.
Now the pathology getting very accurate.
All right, any more? All right, thank you so much for the great talk.